Good evening, everyone. Thank you for this opportunity. Today, I'm going to present a case of acute electric burns. A patient, Mr. X, 25-year-old male electrician by occupation, residing in Chennai, and he is a right-hand dominant patient. He has a sustained injury, sustained electrical burns while working at his work spot. Came into contact with the high tension wire near the transformer to the outer aspect of his left wrist at 1:30 p.m. in Chennai on 16th October 2022. And there is no history of fall or loss of consciousness or ENT bleed, and no history of any other injuries except the burnt areas. And he is referred from the peripheral hospital in Medavakam, from where he was initially resuscitated. And patient admitted in our hospital at 11:55 p.m., almost 11 hours, 11 and a half hours after the electrical burns occurred. There is past history. There is no history of any known comorbidities. And in personal history, he has a mixed diet, a normal sleep, no bowel and bladder disturbances, and he is a smoker and occasional alcoholic, and no other addictions, and no loss of weight or appetite. Treatment history: the fluid resuscitation initiated at outside hospital, but there is no splinting, and the wounds were wounds were covered with a gauze piece with a dressing with silver sulfazine, and catheter was in situ, and no other significant treatment history. General examination: patient is conscious, coherent, and cooperative, and patient is well built, moderately nourished, and has a poor hydration. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, or no pedal edema. At first, the primary survey is done. The airway, breathing, circulation, and are assessed, and the vitals are. The patient is febrile and pulse rate of 118 per minute in the right radial artery, and blood pressure of 100 by 70 millimeter of mercury in the right arm, and the respiratory rate of 22 breaths per minute. After the primary survey, the total burn surface area is assessed to be 18%, and patient catheterized outside is showing very high colored Coca-Cola colored urine. These are the blackish areas are showing the burns involvement. There is involvement of the left wrist on the radial side, left wrist radial side, and near the cubital fossa, and on in the arm, and in the back of the on the posterior trunk, on the occipital region, on the scattered areas over the scattered areas over the bilateral gluteal region, and over bilateral heels. And examination of left upper limb, and in the left upper limb, the arm and the cubital fossa are involved. The second degree superficial or deep burn, and the wrist showed a third degree burn with exposed tendons and charred skin. And the forearm and the hand are tense and with brawny edema, and tenderness is present over the forearm and extending into the hand with minimal passive movements. And the forearm is cold when compared to the right forearm, and capillary refilling time of the fingers showing more of the thumb and the index finger shown more than 5 seconds. And the wound, the 5 to 3 centimeter wound over the left wrist on the radial side of oval shape, exposing tendons, and is neck and is gang showing a charred skin around the wound. with thumb being in IP joint and IP joint and metacarpophalangeal joint being in flexion. The movements of the right of the left upper limb, the shoulder and elbow shows all grade 5/5 active and passive movements, and wrist showed a flickers of movements due to severe pain, and metacarpophalangeal joint and IP joints of all fingers are movements are present but were painful. Paresthesia is present over the thenar eminence, and peripheral pulse are felt but they are feeble. My diagnosis is accidental high voltage electrical burn injury with 18% total burn surface area involvement of post burn day 1 with involvement of left upper limb, trunk, gluteal region, and bilateral heel. And the patient had a compartment syndrome in the left forearm and hand.
Yeah,
continue, sir?
Good. No, I'll just want to stop you to ask a few clarifications. Now, you said when the patient presented to you, he had a silver sulfadiazine dressing on. Why is silver sulfadiazine used for burns?
For burns, the silver ion improves the healing mechanism, sir. Okay. The ionic silver.
Yes. So it's a silver that is going to serve as a transport medium for the antibiotic that you're going to put in. The sulfur is the antibiotic, and the silver ions are able to penetrate through the thick eschar. It is only when the silver is present, they're able to translate across the eschar. So that is why you use silver sulfadiazine. Now, you said that the upper limb is involved in burns, isn't it? You also, in the diagram, I could see that the lower limb also was, you had marked the lower limb areas also. What was the type of burn there? See, on the feet and the leg you have marked. What was the type of burn there?
On the feet, it is second degree deep burn, sir, without any exposure of any tendon or any bony tissue, without any exposure, second degree deep, and over the calf muscle, over the right side calf, it is second degree superficial and second degree deep burn, sir.
Okay. Now, why is it that the feet are involved?
It is the exit point from the entry point is the wrist, sir, left wrist, sir, and the exit point being the bilateral foot, sir.
Good. So it is exited at the feet. What do you think is the depth of the burn in the feet?
Depth of the heel has a thick eschar, sir. Heel has a thick eschar. So the depth of means second degree deep or a third degree, sir.
It is, see, you said deep eschar. If there is an eschar, it is no more second degree. It becomes third degree because the entire skin is involved. Only then you have the eschar. Okay. So here, especially exit wounds of the electrical burns are full thickness burns. Okay. And what happens when the electrical current, after passing through the body, exits through the feet is there is also a small explosion, they say, that is associated. It bursts through. If you would have noticed the leg and the toes, you will see a small burst wound over there. That is because these electrical current, they are in a hurry to run to the earth. That is what they want to do. They want to reach the earth. So when they go down the limb, they come out and they burst through and run inside the earth. And on the limb, you showed different. You showed the wrist was involved. Then you said the cubital region was involved. What type of burn was that?
It's an arc burn, sir. Arc burn, which escapes as intervening normal area and jumps over the low resistant areas, sir.
Okay. Now, when you were talking about the suspected compartment syndrome in the forearm, okay, you were talking about the clinical findings in the hand. Now, what is the most important sign that you need to elicit to come to a diagnosis, clinical diagnosis of compartment syndrome?
Pain of an inappropriate proportion and tense and brawny edema over the forearms. Sir.
There is something else that is more important.
Pain on movements, the passive movements.
Yes, pain on passive movements of the fingers, on passive stretching of the fingers. That is the most important sign, because have you heard of the 5 P's?
Yes, sir.
5 P's.
Pain, pallor, paresthesia, pulselessness.
Yes.
And pulselessness, paralysis.
Yes. So these 5 P's will develop only after the complete compartment syndrome has developed. Whereas you don't want to diagnose it after it's completely developed. If you want to diagnose it earlier, the pain on passive stretching is the most important sign. During the lecture and during the discussion afterwards also, Dr. Bhattacharya ji also was saying, he was saying that you have to, the clinical diagnosis of compartment syndrome is most important, isn't it? So here, and you can do manometric measurements, but the most important thing is the suspicion that it has occurred. And the second thing is the clinical assessment. So here, you must talk about the pain on passive stretch. Then you were talking about joints movements and the position of the joints. What position? Can you show us the picture of the hand? Yes. Yeah, what position? Yeah.
The position of ease, sir, with interphalangeal PIP and DIP joints in flexion position, and and metacarpo MCP joint in neutral position, sir, and wrist in flexion position.
Wrist is actually in neutral position in the picture that you have shown. Anyway, the position, what is the position of ease? You mentioned about position of ease. What is position of ease?
Position of ease is the position with wrist in flexion and the metacarpophalangeal joint in extension and interphalangeal proximal and distal interphalangeal joints in flexion.
Very good. So that is a good position or a bad position?
Bad position, sir.
Yes, that is a bad position. Okay. Okay. Now you have made the clinical presentation, you have made a diagnosis, and you have seen this patient. Now, you have said it. Patient has presented 11 hours after the electrical burn injury, isn't it?
Yes.
And the patient has now presented to you. How are you going to manage?
Can I ask a question?
Yes, sir. Please.
The area of entry was left breast, isn't it?
Wrist.
Left wrist, sir.
Left wrist. Okay.
Yes, sir.
So, how do you explain bilateral exit through heels? Why not unilateral? I mean, usually it is unilaterally seen is more frequent. How do you explain bilateral exit of the current?
Multiple arcs following through the chest wall, sir. Multiple lines.
That means the current crossed over the right half of the body?
Yes, sir.
Traveled through it? How do you explain it as the path of electrical, energy? Because
Yes,
most
sir.
of the time it is unilateral, maybe one shoulder, or maybe skull and so on. But it's interesting to see that there was bilateral exit of same intensity, same location.
Yeah. So when the electrical current enters the body, it tries to, as I told you, the aim of this electrical current that has entered unintentionally into your body, into the body of the patient, is it wants to go into the ground and complete the circuit. So it tries to follow the path of least resistance. It tries to Inside the body, there is less resistance, but there is even lesser resistance outside the body, because the air around the hand or the forearm or around the body is also ionized, ionized. So the current, some of the current can jump like that. It travels through the air. When it goes through the body, which are the parts of the body that conduct the electricity very easily?
Nerves are with the least resistance, sir, which more conductivity.
Are you
and
sure
next,
the nerves have the least resistance?
nerves,
What is it that the electricity wants? It wants a moist environment. Water is the greatest conductor, isn't it?
Yes, sir.
So which is the part of the body that has the water?
Blood vessels, sir.
Blood vessels, yes. That is why all the blood vessels, we were talking about how it goes on increasing the thrombosis, the spreading thrombus. Okay. So when it goes through the blood vessels, it reaches the central part and then runs through the vessels. That is what happens. That is why it bursts through and goes through both the lower limbs, the feet. Okay.
Yes.
Right. Okay. Now, how will you manage?
Initially, when patient comes to the emergency department, initially I will do a primary survey, since it's an acute emergency thing. The primary survey, I will see airway, breathing, and circulation, and confirming that air all are stable. Then immediately I would start fluid resuscitation. And after starting fluid resuscitation, then I will assess the wound percentage and check the urine output. Since the patient is catheterized outside, I will inquire about the urine output and check for the any other sutured wound, suggesting that any history of fall or any history of fall or any other suspicion of any other injuries. And
Sir,
I would.
You are muted, Dr. Karthikeyan.
Sorry, I'm sorry. Yeah, you want to do any, you have said that you want to start fluids. What fluids? How much?
The fluid of choice is ringer lactate, sir. And in electrical burns, since the injury, the tip of iceberg, since injury is more deeper, so we and there is more amount of dehydration. The multiplication factor will be 7. 7 multiplied with the total burn surface area involvement multiplied by weight of the patient in kgs. So according to this patient requires around 9,500 ml in first 24 hours. Since first 8 hours passed away, the next 8 hours comes the 1/4 of this fluid, that is 2,500 fluid will be given to the patient.
Okay. Now you have started the IV fluids, and do you want to do any investigations?
Yes, sir. The first investigation I would do is ECG, sir. Since the arc the entry wound and exit wound are in the hand and the leg, so it should pass through the anterior chest through the anterior chest wall. So suspecting any changes in the ECG, I would first do ECG, sir.
Yes, ECG needs to be done, isn't it? Right.
Yes, sir.
Now, anything else? Now you have to talk to the patient. Okay. Now,
yes,
what are you going to stress on when you're going to talk to the patient? There are about 30 people standing outside your room. Okay. How will you talk to them?
I would first ask the more distant relative and reliable relative who will be present through all over his treatment period. I would talk to that person, and and the next thing is I would explain if now the patient has a wrist involvement, and with a deeper burn. I would explain the requirement of multiple surgeries or requirement. First, I would explain about the nature of the electrical burns and how depth the electrical burns would go, and how it will be differentiated from the flame burns. I would explain the patient, and I would let him know the severity of the electrical burns. And next, I would explain the cardiac manifestations that can occur through electrical burns, and that may cause mortality of the patient. And next, I would explain the requirement of emergency surgeries or the emergency surgeries for the patient for salvage of the limb. If the salvage is not possible, I would explain the patient attendant about amputation requirement of amputation will be decided when after if the limb is not salvageable.
See, the first thing the attenders want to know is whether the patient, there is any risk to the life of the patient. What are you going to tell about that?
Since the electrical burns is a tip of iceberg, I would explain that the whatever which is visible outside is not the same which is inside the body, and the cardiac changes and the acute renal failure may occur within first few days, and also the first few days. So there is risk of mortality.
Mortality, yes, that should be explained to the patient. And then you talk about the risk. First, risk to the life, then risk to the limb, and then what you are going to do. Okay, yes. And you're going to tell them about an hospitalization. Then next, they want to know about how long it's going to be hospitalized. Some people may be thinking you'll be doing some treatment and discharging him also. So you need to tell them about the probable duration of hospitalization. That also, what would you say is the probable duration of hospitalization for this particular patient?
This particular patient, I would say around one to 1.5 months, sir.
Yes, you have to mention that. Okay, right. Now please go ahead. You kept talking about tip of the iceberg 2 or 3 times. You want me to ask you a question about the tip of the iceberg? No, yes, please tell us what is this tip of the iceberg thing.
The wound outside, or the wound outside is looks to be smaller, but the inner involvement of muscle and bone might not be visible from outside, but there might be involved.
Why is the involvement of the bone more than what is the involvement of the skin?
Since there's a Q is equal to I square R, sir, the energy is the square of current into the resistance. As there is more resistance, the most resistant part to the electricity is bone, where there will be more generation of heat. So there will be due to more generation of heat, there will be charring of the bone.
Yes, there will be charring of the bone. Not only charring of the bone, the heat will also destroy all the tendons and muscles that are close to it, isn't it? So that also will be involved. Whereas, why is the skin involved? What is the involvement of the skin here?
The skin is also a skin at the wrist. It's involved since there is the moist area has less amperage of current.
Moist area has less resistance. Less resistance. Yes, it has got less resistance to the current. Okay, so what happens because it has got less resistance to the current? It allows the current to enter. Okay, Now it has allowed the current to enter, isn't it? What about dry skin? If it had been dry, would it have prevented this electricity from entering?
The intensity will be lesser.
Yes. The resistance offered by dry skin is around 5,000 ohms per square centimeter, whereas the resistance offered by moist skin is barely 300 ohms. So the difference between 300 ohms and 5,000 ohms. That is why it enters through moist skin. Okay. Now it has electricity has allowed the current, and the skin has allowed the current to enter. You said if there is resistance, there will be heat generation. But here there's no resistance. Why should it be damaged?
Contact time.
Why is it damaged? Why is the skin damaged? You have already told the answer in a previous question. What was it? When I asked you, what conducts the electricity easily?
The blood vessels.
Blood vessels, yes. So they go in for necrosis, coagulation. It's like applying a large diathermy, isn't it? So like a diathermy, it coagulates all the vessels. That is why the skin breaches and the skin breaks open. Okay, so that is what is happening. Right. So now you have talked about the tip of the iceberg. Okay. Now please go ahead. What you're going to do next?
I would investigate the patient, sir. After echo ECG, I would do the renal function test, liver function test, and the complete blood picture, and the chest X-ray, and opinions of the neurosurgery and neurosurgery and the cardiology are taken, sir. And
now you have the catheter is already in, isn't it? And the patient you said is Coca-Cola colored urine. It's very high colored urine. You have admitted the patient, you have started on IV fluids. Is there any monitoring that you want to do?
Urine output monitoring.
Yes. Can you be more specific? What do you want to see in the urine output?
Urine output.
What is the rate of
color?
How frequently you monitor the urine output? How frequently you monitor?
Every hourly monitoring, ma'am. 100 ml per hour is the.
Yes, you want to make sure that the patient is putting out about 100 ml per hour. If he is putting out about 100 ml per hour, that means the urine is not, the kidney is not going in for acute tubular necrosis. And second thing, you also want to monitor the color of the urine being formed. Why is it Coca-Cola color in the first place?
Myoglobinuria, and due to myoglobinuria, sir. Due to muscle, there is excessive damage to the muscle, which releases myoglobin, which passes through the renal tubules, causing acute tubular necrosis also, sir. And in the urine, there will be myoglobinuria, sir.
Correct. Okay. So now you have monitored this patient, right? Now what are you going to do next?
Based on that, I would after giving adequate fluid resuscitation, since the left forearm and arm, I'm suspecting a compartment syndrome. I would first see. I have seen the patient for 2 hours after to elevate the limb and elevate the limb. If there is any reduction in the edema or tense or pain, reduction in the pain.
Can I stop you for a minute? When you suspect a compartment syndrome, would you elevate the limb? When there is a compartment syndrome, when you suspect a compartment syndrome, is it good to elevate the limb or keep it at heart level or keep it down? Which is better?
Heart level, sir.
Keep it at heart level, because already the arterial supply to the muscles are all going down. That is why the muscles have gone in for edema. If you elevate it further, it is going to further compromise. Okay.
Yes.
So usually we keep it at heart level. Right.
Yes.
So you want to monitor this for 2 hours, and then what decision will you take?
If the edema and or pain during passive stretching doesn't reduce, and immediately I would take for an emergency fasciotomy.
How will you do that? What investigate? I mean, what anesthesia? How will you do the procedure? Where will you do the procedure?
Yes, sir. After investigating the patient, getting a preliminary investigation of hemoglobin and blood grouping. I would immediately in a emergency operation theater under axillary blockage, under tourniquet control, I would do emergency fasciotomy.
Yes. Why do you want to use a tourniquet?
See, there may be sudden bleeding from the venous bleed, to control the venous bleed, sir.
Yes. How long will you apply the tourniquet for these patients with fasciotomy?
Around 15 minutes, sir. 15 minutes would complete.
Do you want to keep it as a mathematical 15 minutes, or will you relate it to your surgery procedure?
Surgery procedure, sir.
Yes. So if you finish your fasciotomy in 5 minutes, would you want to continue the tourniquet for 15 minutes?
No, sir.
So you have to release the tourniquet immediately after your fasciotomy is over, so that you can get hemostasis of the bleeding vessels, the veins. Now, how will you plan what incision would you make for the fasciotomy?
For fasciotomy, the incision is the going in the palm, going along the thenar crease, and at the wrist level there is slight at the wrist they're forming an angle, and into the forearm, extending into the distal forearm.
Distal forearm, you want to stop only in the forearm?
Extend to the level of arm if there is also arm is also tense.
Okay. Now this skin incision that you have marked. Okay. Now how deep you are going to make the incision? Can you tell us about the details? Can you tell us about the details of how you will do this surgery?
Yes, sir. Yes, sir. Under tourniquet control, first I would with a 15 number blade, I would first start my fasciotomy incision from the thenar crease. The skin deeper fascia are cut such that the muscles underneath are popped out, and in the fasciotomy we have to see the ulnar pedicle, ulnar nerve and median nerve, such that they are not compressed.
No, 1 minute. You are still in the thenar crease.
So thenar crease extending in the wrist at an angle, and extending into the distal forearm in the mid forearm.
From after the thenar crease incision, you came to the wrist, isn't it? Now there is one important structure under the distal to the wrist. What is that structure?
Median nerve, sir.
No, something more superficial than that. The median nerve, something that is covering the median nerve.
Would you like to cut something there?
Flexor retinaculum.
Yes, you have to do a decompression of the
flexor carpal tunnel.
Yes, you need to decompress the carpal tunnel. Now, while making this incision, distal to the flexor retinaculum, there is an important structure that you should not damage. What is that?
Median nerve.
No, that is deeper. I'm talking about distal. There is some structure that runs like an arch.
The superficial palmar arch, sir.
Yes. Yes, that is just under the skin. Okay, that's under the palmar aponeurosis. And now you cut the carpal tunnel, the flexor retinaculum, which is the level of the palmar aponeurosis, isn't it? So you should be careful you don't damage the superficial palmar arch. Now you have done a carpal tunnel release, decompression. Okay. Then what do you do? Is there any other tunnel nearby that you may have to decompress?
Guyans canal for ulnar
Yes.
nerve, sir.
Yes. Where is the Guyans canal in relation to the carpal tunnel?
Guyans canal is more ulnar towards the ulnar side of the carpal tunnel, sir.
Yes, it is the ulnar side of the carpal tunnel, and you talked about the flexor retinaculum. The flexor retinaculum, is it part of the Guyans canal?
No, sir.
Yes, the flexor retinaculum forms the floor of the Guyans canal. Okay, so that you must remember when you're going in to release the Guyans canal also. Okay, right. So now you have now come to the wrist. Okay, as you said, you have to be careful about the median nerve, which is just under when you release the flexor retinaculum. Now in the wrist, what is the depth of your incision and what will you do?
Depth of incision is I should incise the deeper fascia, sir.
You should what?
Just lateral at an angle. I will go at the wrist, and the exposing the median nerve, exposing median nerve. I would extend into the forearm.
Yes.
Distal
And
forearm.
what level? What are you incising in the forearm? The skin.
Deeper,
then
deep fascia, sir.
deep fascia. Very good. How many compartments are there in the forearm?
Superficial compartment, intermediate, and the deep compartment, sir.
What is intermediate compartment? There is only superficial compartment and deep compartment. Yes. Okay. So now you want to release the deep fascia, isn't it? Right. After releasing the deep fascia, throughout, you said you want to go from the wrist up to the proximal, almost to the proximal forearm, and sometimes up to the arm also, isn't it?
Yes,
that is how you have to make the incision. And throughout the entire length, you're going to incise the deep fascia, isn't it?
yes,
What are the structures that you're going to encounter while you are making this incision under the skin?
The superficial veins will be encountered, sir.
Excellent. Superficial veins. Yes, they are very important because they can cause a lot of bleeding. Now, after releasing the pressure, these veins will start bleeding, right? You have to be very careful and get good hemostasis. You should talk about these veins when you're talking about the fasciotomy. Right. Now you have made the fasciotomy. Okay. And the muscles bulged out, as you said. What are you going to do now?
Immediately after completing the fasciotomy, I would after visualizing.
Fasciotomy is not completed. What will you do? That is an important. Yes.
Tourniquet should be removed.
Before that, you talked about superficial compartment and the deep compartment. What are the muscles in the deep compartment?
Flexor digitorum profundus.
Yes. Then
the flexor pollicis longus.
Very good. These two important, and of course the pronator quadratus also. These are the three muscles in the deep compartment. In an acute compartment syndrome, as you are seeing in electrical burns, which is the compartment that is most often involved?
Superficial compartment, sir.
Come on.
Deeper compartment.
Yes, there are only two, men, either superficial or deep. Okay. Why is it that the deep compartment is involved?
Less some space.
One is less
compartment.
Yes. It is a closed compartment. One side is bone and the interosseous membrane that do not allow it to expand. Okay. And on top of it, you've got a deep fascia, isn't it? So that way, this is much more, and the vessels are all here in this compartment. Okay. So the smaller vessels here in this compartment, they are more prone for getting compressed. So when you make the fasciotomy, it is very important that after incising the fascia, you put your hands in, open out the muscles. Then you will come across the deep compartment fascia. Release that also. You should be able to see all the muscles individually. You should be able to see the median nerve. You should see the entire length of the ulnar nerve and the median nerve. And if you possible, you can also see the radial artery and ulnar artery. This is how a fasciotomy should be completed, right? Because to make sure that there is no, I have seen patients where a fasciotomy was done and only the superficial compartment was released. So what will happen is deep compartment muscles will go in for necrosis, right? So to prevent that, you have to do a complete fasciotomy. Yes, now you have done a complete fasciotomy, you have released all the muscles, you have released the nerve, entire length of the median nerve and ulnar nerve in the level of the forearm, and then you have ligated all the veins that have been injured in the fasciotomy, skin incision. Right, now what are you going to do?
I would release the tourniquet and see for the any bleeding, sir.
Yes.
Hemostasis, achieving hemostasis.
Yes. Now, this patient has come to you 11 hours after the injury, after the electrical burn. Now you took, I will assume you take about 1 hour for the resuscitation and all that. And you said you want to observe for 2 hours. So now another 3 hours have gone, isn't it? So now it is 14 hours since the electrical burn injury. Now, when you do a fasciotomy and release the tourniquet, do you expect something to happen? Now, all the toxic substances that were there, they're all, what is going to happen?
The urine gets clear, sir.
No, it won't get clear, it will get worse. See, all the toxic substances that were there, okay, they were not able to go out. Once you release the tension, all the the muscles have been released, okay, but the toxic substances, what happens when there is ischemia for about, this is about 14 hours. Remember, the muscles have gone to ischemia for 14 hours. What is the ischemia time for muscles?
6 hours.
6 hours. Now remember, your patient has gone through 14 hours. Okay. So what has happened inside the muscle? What substances have built up inside the muscle?
Myoglobin has accumulated, sir.
Myoglobin has been degenerated and it has gone into the circulation. Second, what else a substance has built up? Because the muscle also is trying to breathe. There is no oxygen. So how does it respire?
Anaerobic respiration, sir.
Yes.
Lactates are included.
Accumulated. Okay. So
there is a lactic acidosis.
Lactic acidosis. Okay. So lactic acidosis now occurs. You should be prepared for this. When you release the tourniquet, especially after 14 hours of ischemia, when you release the tourniquet, you should be prepared. Lactic acidosis, you don't have to worry much about it. It's not a very big complication. But you need to rush in IV fluids at this time. It is important. Otherwise, it may compromise the respiration of the patient. Okay, right. So you have done a fasciotomy very successfully. What are you going to do now?
I would observe the patient next 24 hours for any bleeding, soakage
so
of the.
To leave everything open so that everybody can see what is happening. No dressings.
Close dressing, sir.
That's all. Only dressings.
What type of dressing is applied? Is it
compression
bulky?
Dressing, bulky compression dressing along with hand elevation.
Yes.
Hand elevation and giving a appropriate splint.
What is appropriate splint?
Giving a splint in functional position, sir.
What is functional position?
Functional position is the metacarpopharyngeal joint at 90 degrees and proximal and distal pharyngeal joint extended and thumb in palmar abduction. The glass palmar abduction.
Of the wrist?
Wrist is in extension, sir.
Wrist is in extension. You want to put the wrist in extension. Okay. So now you want to put a bulky dressing and you want to put a POP. Are you going to put the POP on the volar side or on the dorsal side?
Functional volar side only, sir.
Are you sure? There is
yes,
a
sir,
dictum. There is a dictum in hand surgery that whenever there is a compromise in the vascularity of the hand, always use a dorsal POP. Okay. And Second, then the other dictum is whenever there is a compromise, here there is a compromise in the vascularity, isn't it?
Yes, sir.
So the second thing is never put the wrist in extension. You want to make sure that the blood supply is very smooth to the hand. So always a dorsal POP with the wrist in neutral position. Okay, so you got that now, right?
Yes.
So you put a POP and you have advised hand elevation. Then what are you going to? How are you going to follow up the patient, monitor the patient?
I will monitor with the urine output, sir. Since the toxic substances are released and also adequate fluid resuscitation in the next 8 hours, next 16 hours are given. So I would expect the urine color to be more clear. Urine color to be more clear, and output should be output to be increased.
Yes. Then what else you want to monitor?
I would monitor the vitals, sir, pulse rate. The pulse rate tachycardia indicates any there is tachycardia indicates there is involvement of SIRS, systemic inflammatory response syndrome. So I would and also I would repeat the renal parameters after 16 hours, sir.
Okay, now you have monitored the cardiac state, general condition of the patient, and the renal output you are monitoring very well. What else you want to monitor?
I will monitor liver function test, sir. Liver enzymes are also reached.
Yes. Now you have done a surgery mainly for what purpose?
To relieve the compartment and to relieve the, to remove the toxins.
Do you watch the fingertip? Do you watch the fingertip?
Yes, ma'am.
That is important, isn't it? You have done the surgery to improve the vascularity of the fingers. So that also should be monitored. Okay. So general condition, along with the general condition, also the condition of the limb and the fingers should be monitored, right?
Yes.
So now you have done the surgery, you're going in again after 6 hours, and you see there is a lot of soakage of the dressing. What will you do?
I would open the dressing, and if the soakage is serous or serosanguinous or sanguinous, clear blood, I will see that. If there is any active blood, I would immediately ligate that superficial vein from which the bleeding is occurring. And if there is serious discharge, I would redo the dressing with a bulky pads.
Okay. Now the patient, you have done the dressing. What is your next plan?
Next plan, after 72 hours, I would plan for a wound debridement. And to know the status of the muscles underneath and also the tendons, which all are present, which all are damaged.
Now, what do you expect in this patient?
Since I expect the tendons and the skin is charged and tendons being sloughed. Tendons are sloughed, and it's a close proximity to the radial artery. So I would also visualize the radial artery, and if there is any chance of any radial artery involvement, if it's not salvageable, I would ligate the radial artery.
Okay. Now you said you wanted to debride at the end of 72 hours. Okay. Right. At the end of 72 hours, when you debride, you find that the bone is exposed, the lower end of the radius is exposed, the tendons are all charred. Okay. And the fasciotomy, through the fasciotomy, you can see all the muscles are nice and red. You can see fine granulation is appearing over the muscles. And you can also make out that there is a necrosis of the tendons on the volar aspect of the distal forearm. Okay. What are you going to do?
The sloughed tendons and the sloughed tendons are debrided until there is healthy tissue, and if and the bone which is charred off is nibbled. The exposed radius with charred margins are nibbled, and the blood vessel which if involved is carefully ligated.
Okay, then that's all. You want to do a debridement only, or you want to give a flap cover now? It is 72 hours since the injury.
Sir, I would do serial debridement, sir, since the disease is, the electrical burns is progressive. I would every second day or third day I would debride the wound, and confirming that the wound is healthy and it's not progressing. Now, mostly after 7 to 10 days, I would give a uh, flap cover for the defect over the wrist, sir.
Yeah, so it's going to take you about, you want to plan the flap cover in about 7 to 10 days, isn't it? Right.
Yes, sir.
Now, you have talked about the hand. I am also worried about the other wounds on the body. You told me there is a wound on the scalp. You told me there are wounds on the feet and the leg and the back also. Now tell me
Yes,
how
sir.
you're going to manage those.
Uh, uh, except the healed wound, other wounds are appears to be second degree superficial without exposing any vital structures. So I would serially debride the dead tissue if formed, and after when we are planning a flap cover, when there is any second degree superficial, I would skin graft it, sir.
Yeah, so you want to do the skin grafting for all the other. There is a big wound on the back also, I noted.
Yes, sir.
Yeah, what are you going to do for that?
There is the wound over back is doesn't it is second degree superficial and areas of second degree deep burn, sir. I would serially debride it, and when there is healthy granulation tissue, I would put a skin grafting over it, sir.
Now, when do you plan to put a skin graft on the back wound?
Patient is mobilized.
After the patient is mobilized, when?
Sir, since that is also an electrical burn,
Yes.
so I would wait for 7 to 10 days,
Yes.
and the regular dressings of the wound is done till 7 to 10 days,
Okay. So at 10th day, you want to put a graft.
Along with the flap coverage, sir.
Yeah. Now, if you put a graft on that area and you give a flap, patient is going to lie down on that graft.
Yes, sir.
Would you accept it, or would you do something else?
I would delay it, sir.
Delay what?
Delay the only only the other areas. The other areas I would graft it, but the areas which are dependent, I would keep it for after the division of the flap.
Now, when are you going to? I mean, it depends on what flap you're going to do. What flap have you planned for the wrist? Dr. Lakshmi, madam, do we have time? And I think it's 2 hours since we started.
No, sir. We have time.
Okay. Okay. Go ahead.
Till 8:30 it is.
Oh, okay, madam. Yeah. Yes, Teja.
I would plan for a abdominal flap, sir. Since the area of coverage, since sir, can I show the photographs of this?
Yes, please.
Sir, this is of other patients, sir. I would not find the markings, so I have kept for fasciotomy, this, sir.
Yes, no
And
problem.
this is
All this. Yeah.
This is the wound, sir. After giving a fasciotomy wound on the second day after 72 hours, when we proceeded with for debridement, we have sutured the fasciotomy wound, sir.
Yes.
Sutured the fasciotomy wound, and for the carpometacarpal joint, and also the radius is exposed with charring, sir. So for CMC joint stability, K-wire was put, sir, and the tendons which are slugged are ECRB, ECRL, FCR, ECRB, ECRL, APL, EPL, and EPB, sir.
So which compartments have been involved?
First, second, third extensor compartment, sir, and FCR, sir.
Okay. Now, what about the flexor tendons? I can see what I can see. I can see some whitish tissue there in the front of the wrist, distal forearm?
Palmaris longus, sir.
No, the other tendons. Okay, so they are all intact. Flexor tendons are
Yes,
intact?
sir. They're intact, sir. Intact, sir.
Very good, very good. So what is your plan now?
My plan is the serial wound debridement, sir. Serial
Yeah.
wound debridement. This is the wound, the post wound debridement at the day of day 9, sir. Then
Very
we
good.
planned for an abdominal flap cover.
Ah,
Abdominal flap cover, since the raw area is bigger, I would choose a superiorly based abdominal flap, 11 into 13 centimeter, and the donor area is donor's site is grafted, and the flap insert is given, sir. Given. And
okay.
this is
Yes.
and I would, after 2 weeks, I would delay the flap, since the area of involvement and also the radial artery is ligated, sir. So I would delay the flap to improve the vascularity of the flaps, sir.
Yes.
And after 1 week, on the day 33, I would give a I would divide the flap and give a insert, sir.
Okay. Now, at the end of 3 weeks, you're actually dividing the flap, isn't it?
After end of 3 weeks of the abdominal flap, sir.
So after 2 weeks, you did a delay, then you did a division. Yeah. Okay. Then
2 days later, sir. 5 days after the flap division, sir.
okay, right. Now, what is your next step?
Parallelly, I have done skin grafting for the heel, calf, and also arm and forearm, sir.
Okay.
The
now
second look is
the graft take is good on the other areas also. Okay, very good. Now, there is one thing about burns on the back, some salient point about it. Can you tell me what it is? What is the thickness of the dermis in the back of the back? It is thinner or thicker, the dermis?
Dermis is thicker, sir.
It is thicker, obviously, isn't it? So when the dermis is thicker, even at same depth of burn over the rest of the body and over the back, you will find that usually the back burns, even second degree burns, will usually heal with time. Okay, that is important because the amount of dermis is more. So that is why you can delay the skin grafting for the dorsal, for the back. Okay, right. Right. So now you have done a flap cover and you have covered all the areas. The back also, you said you want to do a skin grafting if there is a raw area. Right. So you have healed the wounds. What are you going to do next?
After there is a stabilization of.
I remember you had put in a K-wire through the first metacarpal into the radius.
After 3 weeks, we have removed when the flap division is done, sir.
You have removed it at 3 weeks.
We have removed now, sir.
You have removed now at this stage. Okay, right. So after doing this flap inset, the wound has healed. What are you going to do? How are you going to follow up, or are you just going to send the patient out?
Okay. I would give a initially after the flap division, I would give a limb elevation and with a functional splint, sir. Functional splint, and
I don't understand what is functional splint.
Now, what is the splint that is given for this patient?
This the dorsal POP with metacarpophalangeal joint in at 90 degrees and DIP joint and PIP joint extended, sir, and wrist in neutral position.
I am not interested in the splint that you're giving for the fingers. I am more interested in what you're going to do for the thumb, because that is the fellow who is actually involved now. Yes, what are you going to do for the thumb?
Palmar abduction. I would keep the thumb in palmar abduction and give a splint, sir.
What are you
Thumb
going
spice.
to? What are you achieving by keeping the thumb in palmar abduction? Why in palmar abduction?
The functional position such that
Yes,
contract
functional position. Yes. Then
contractures are contracture band between the is longer, sir.
contracture band is longer. No. Now,
What are the tissues that are lost?
The tendons to thumb extensors and thumb abductor is lost, sir.
yeah. So what will happen to the thumb now?
Thumb will go into adduction position.
Yes, correct. It's going to adducted position and flexion position. You don't want that position, isn't it? So you want to keep it in palmar abduction so that one more important structure is maintained, one important landmark. What is that landmark between the thumb and the fingers?
First ribs.
Thumb web is very
Thumb
important.
web.
By keeping it in palmar abduction, you are maintaining the thumb web. That is also very important. If you don't take care of the thumb web, it will go in for contracture again. Okay, right. So now you put the thumb in palmar abduction. Now, when you put the thumb in palmar abduction, what happens to the carpometacarpal joint? In the joint, no?
Yes, sir.
Yeah. Would you take an X-ray after this POP and after this debridement?
Yes, sir.
To see what?
To see the joint space, sir.
Yes, good. Yes. Yeah, you have done. Yeah. Yes.
Joint space and
joint space mainly. Okay. Now, there are two things you're worried about. One is the carpometacarpal joint of the thumb. Second is you said there was some charring in the lower end of the radius, of which you did bone nibbling, isn't it? Now, these two things should be sitting on the back of your mind whenever you see the patient at follow-up. Your skin is all settled, but now you have to give back function, isn't it? So when you put the patient, when they put the thumb in palmar abduction, the carpometacarpal joint, okay, it sits in this position so that it is absolutely opposed. The base of the metacarpal opposes completely to the trapezium. So that way, all forces that are transmitted through the thumb are equally transmitted through the trapezium and up along the forearm and arm. If you keep it in adduction, there is an unequal balance between the trapezium and the first metacarpal bone. That is why you have to keep the thumb in palmar abduction. Okay, right. Now what are you going to do next? Patient has come to you again after 6 months. He is wearing the splint correctly and he is doing a correct scar massage. He's come to you now. What are you going to do?
I would explain you about the reconstruction of the lost tendons, sir. Reconstruction of the lost function.
Yes.
The extension, thumb extensor should be reconstructed, sir, along with the FCR. Since the patient may go in, since FCR and also the ECR and ECRB is lost, the wrist can go into ulnar deviation. So I would reconstruct.
If you are asked this question, what are you going to do after 6 months? I would say I would reassess the patient. I would reassess the hand function. What you had lost was ECRL, that is all anatomical loss. Okay. What is the functional loss you have to assess after 6 months? He's coming to you after 6 months, I told you. So after 6 months, you have to assess the function of the hand and then decide on the reconstruction. You can't plan a reconstruction based on what you saw 6 months back. You understand? You yourself said very correctly that you want to do a functional restoration, isn't it? Reconstruction. So you have to assess, right? Now let us assume that all the muscles are intact except the extensors of the wrist and that is the ECR and ECRB have been lost. But do you think he'll have extension of the wrist now?
The ECU will take care of the extension, sir.
Very good.
Of the
You will take care of the extension. Now, what about the thumb? Is there any muscle that can take care of the extension of the thumb?
no, sir. All the three are lost.
What
So,
is the three? What are the three?
APL, EPB, and EPL, sir.
Huh? What did you say?
APL, EPL, and EPB.
Yeah, APL, EPL, and EPB. Yes. How are you going to reconstruct?
I would reconstruct the EPL, which is to the metacarpophalangeal joint with the extensor indicis pollicis, sir, tendon which is intact. I would transfer the tendon to
the EPL.
to the distal end of the EPL, sir.
To the distal end of the extensor pollicis longus. Okay. Yeah. Now, when you're taking the extensor indicis proprius, at what level are you going to divide the extensor indicis proprius?
The exact measure.
No, at what level? At what level will it approximately you'll be making the incision? Now you have to make an incision to harvest the extensor indicis proprius, isn't it?
I would make at the first second metacarpophalangeal, just below the metacarpophalangeal joint, sir.
Proximal or distal to the metacarpophalangeal joint?
Proximal, sir.
Proximal, then it may not reach. You said you want to put it to the distal EPL.
Yes, sir. So distal length to attain length, distal to the metacarpophalangeal joint.
Yes.
I would give an incision, and through railroading, I will the proximal end of the tendon is brought to the first through the first web space. I would bring to the distal end of the EPL tendon.
Okay, and what sort of suturing will you do?
I would do horizontal mattress, sir.
Supposing the EIP tendon is very thin and the EPL tendon is quite large, is there any other method of suturing you can do? When you have a small tendon and a big tendon, is there any weaving technique you can do to have a good suturing?
Yes, sir.
Have you heard of Pulvertaft weave?
Yes, sir. Pulvertaft weave, sir. The major tendon will make incisions, and through that, like this, will sir.
Okay.
Tibialis anterior transfer the EHL.
Yes. Okay. So now, when you're doing after doing this transfer, okay, how long will you immobilize the thumb?
I would immobilize the thumb for 3 weeks, sir. In a POP cast, and start the active mobilization, active flexion, and after 3 weeks continue for 2 weeks, and after the active extension of the next 2 weeks, and then followed by passive movements.
Passive movements. Okay, right. So now you have reconstructed. Now supposing in this patient, you find that the joints were stiff, the thumb web was stiff. Patient did not wear his splint at all in the 6 months. He has come to you at the end of 6 months with a thumb web contracture and the thumb is adducted. What will you do?
I would first release the thumb web contracture, sir. Through Feynman flap or multiple Feynman flaps, sir. And I would and the remnant raw area over the thumb web space will the full thickness skin grafting can be done, sir. such that creating.
1 minute. You want to put a full thickness skin graft on that raw area after releasing the thumb web?
Yes, sir.
How is the thumb web usually reconstructed?
If the raw area is there, sir, otherwise we will give a jumping man flap, sir. Five flap technique, and
What is five flap technique? What is five flap technique?
five flap technique, 2 Z-plasties followed by YV advancement flaps, sir, in between.
Okay, so 2 Z-plasties with a YV advancement. That is possible only if there is enough skin on both sides, isn't it?
Yes, sir.
Okay, right. So you can do that also. Now, when there is a thumb web contracture in this sort of patient who is coming to you after 6 months, it is not only the skin that is involved. What else is contracted?
Bony ankylosis will also be there, sir.
What else is contracted? Some mobile structure has now become short. Some muscles are,
The tendons.
Tendon.
What is there in between the thumb and the first metacarpal, the first and second metacarpals?
Because there is no abduction of the thumb. So which is the muscle that doesn't have any resistance at all?
Acts more.
Abductor is not acting. It's paralyzed. It's lost. Isn't it? So which is the other muscle that doesn't have any resistance now?
Adductor pollicis.
Adductor pollicis. So now adductor pollicis, that is under the thumb web, isn't it? It forms the thumb web. So what happens to the adductor pollicis if splints are not given and mobilization is not done and abduction is lost? So what will happen to the adductor pollicis now?
Will be in the contracted state, sir.
Yes, it will be fibrosed, contracted and fibrosed, right? You have to release this adductor. Only then you can get out the thumb. This is an important point. If you think that the thumb web contracture is only about the skin, please change that concept, because the muscle underneath here, especially in this patient, the muscles, the opposing muscles, antagonistic muscles are all lost. So the agonistic muscles, the adductors will go in for, they don't have work at all now. So they go in for fibrosis. You have to release them. How do you release the adductors? Do you cut the muscle, or you erase them from the origin, or you erase them from the insertion?
To get
because only to release this muscle, your thumb web will come out.
Yes, sir.
Yeah. So how will you release it? You have to erase the adductors from the insertion. Where are they inserted?
They inserted in the metacarpal base, sir.
Metacarpal base?
Metacarpophalangeal joint.
Yes, around the metacarpophalangeal joint and the neck of the first metacarpal bone. So they have to be released from here. Only then the thumb web can be released, right? So then you have to release the thumb web, give a flap cover, and then do what the procedure you talked about. No, you talked about using the extensor indicis proprius, right? Okay. Yes, now this patient, when you saw him at 11 hours after the electrical burn, okay, he tells you, I am a great VIP, I am a celebrity. I cannot sit here for 1 month as you are saying. I want to go home in 10 days. What will you do?
I'll counsel the patient that it's not possible.
Good. First thing, very nice. I like that. You counsel the patient, it is not possible. We are sure about our medical and understanding. Okay. Just because you happen to be a celebrity, science cannot change. Okay. I like that answer. Yes, you have to counsel them. It is not possible. You can tell them, however, I can reduce the time gap because I can modify my reconstruction, but I cannot change the nature of the wound. Right?
Yes.
Okay. Now, okay. Patient says, okay, doctor, I agree with you. but you said that you'll give a flap cover only after 1 week or 10 days. Can you give a flap so that I don't have to have my hand stuck to my abdomen?
If there is any small raw area, I can try a local flap, sir.
For this patient, we're talking about this patient.
Free flap, I would advise.
Just show us that picture. Debrided wound. Yeah, stop. Yes, tell us now.
I would, if the distant flaps are not, if the patient is not willing, I would advise for a free flap transfer, sir.
Yes, good. What flap would you advise? Would you do?
I would advise the free ALT flap cover, sir.
Very good.
Facial cutaneous flap cover, I would advise for this, sir.
Okay. Which vessel would you use for the anastomosis?
I would use the vessel is not this.
What vessel you're going to use? You're going to do a free flap. Tell us what vessel you're going to use. There is already one vessel which has been damaged. Why do you use that vessel?
Yes, sir. The proximal end of the vessel.
Yes. So the proximal end of the radial artery, anyway, it's damaged, no? So you can use that vessel, right? Okay. So you want to use you can do a primary reconstruction with a free flap. So the patient is asking you, doctor, you told me that after 6 months I must come for a tendon transfer. I cannot come. I told you I'm a celebrity. Okay. You said you want to do some microvascular surgery. Can you finish that surgery that you planned after 6 months? Can you do that now itself?
In acute condition, there will be
Think, yes.
Can you add any tendon to the free flap that you told?
Skin is lost, you're planned for a skin reconstruction. Tendon is lost, what can you do now?
Tensor fasciolata.
Yes, tensor fasciolata, tendon graft you can do, go distally. Anyway, you're giving a good skin cover. Why don't you go ahead with the reconstruction also? Okay, so the moral of the story is there are two different types of management of this case. Okay, but the baseline of everything is, as you said, the biology of the wound, of the electrical wound, which is going to take its own sweet time. Up to earliest you can do is 7 to 10 days. By the time you are able to get a control of the wound, only after you get a control of the wound, you can decide on what you're going to do. You can put a free flap, you can do a pedicle flap, whatever. Okay?
Yes, sir.
So whenever you talk about a plan for a patient, for a raw area or a defect, always make two plans. One plan is an ideal plan and one plan is a practical plan. The two may not be the same. Okay? So always make two plans so that when you come across a situation where everything is available and you have to do an ideal plan, no? You should be able to, you should be ready to do it. Okay? Good. Nice presentation, Dr. Tejaswi. Nice presentation. Thank you.
Thank you, sir. Any doubts from pages? Sharika? Yeah,
Dr.
I ask.
The hand.
Ma'am, Dr. Shailesh has raised his hand.
Yeah.
There's nothing in the chat box yet.
Good evening, sir.
Yes, Shailesh.
Sir, you had mentioned that we can use the radial artery for the free flap anastomosis, sir. Since it is already suspected to be damaged, is it safe to use that vessel, sir, or will it go for thrombosis again, sir?
Yes. Dr. Teja, can you answer that question? He wanted to use. I gave a suggestion. He only said he wanted to use the radial artery. Yes.
Okay.
Would you defend that, Dr. Teja?
I would give you a free flap cover after a minimal after a duration of 7 to 10 days, such that the extension of the thrombi may be reduced, such that you will find the proximal pedicle which is healthy, which have been ligated.
Yeah. So the thing is, in an acute injury, we have not taken it immediately. Okay. And so there are 2 or 3 precautions that you take when you take. Your question is very relevant. Can you use the radial artery now, even though it is damaged distally? The damage is also going to be proximal. How can we take the radial artery proximally? There are a few precautions. One, you wait for about 7 to 10 days. Second, you go much proximally. You can go very proximally and take it. After all, you're taking the anterolateral thigh flap, which gives you a very long pedicle, right? Third, after you select the radial artery and dissect the radial artery, you need to cut it to see the flow that occurs. Okay, so this way, supposing you find a good flow in the radial artery, it doesn't mean it's going to get thrombosed because you waited for 10 days. The process is no longer going to increase, right? So now, if you see a good bleeding from the radial artery, you can use the radial artery for the anastomosis. There is no problem at all. Remember, waiting for 10 days minimum. Second is going as proximal as possible. You might have all, I think you are worried about the zone of injury. We always talk about the zone of injury. Now, I want to make one clarification about this zone of injury. Even in trauma, no? If you are going to do the microvascular surgery within a period of 3 weeks, if you cut the artery and you see a good bleeding, that means it is a good artery. The same artery, if you're going to see after, say, 6 months or 3 months, you cut the artery and you find that the bleeding is good, it is still suspect, because there is fibrosis around the artery and the artery can go in for spasm. This zone of injury is only applicable in the chronic patients. In the acute patients, if you see a good artery bleeding, it is a good artery. That's all. There is no question about it. The zone of injury comes into the concept of zone of injury comes into play only in the chronic cases. That is why I say acute injuries, it is much easier to do a free flap. In chronic injuries, you have to dissect through that scar and remove whatever skin graft has been applied and then get the vessel. Even if you get a vessel, it may not be good. So that is why this zone of injury concept, but in electrical burns, in 7 to 10 days, you are still within the acute period. If you get a good bleeding proximally in the radial artery, you can always use it.
Thank you, sir.
Any other doubt? Charika?
No, ma'am, the chat box is empty. Nobody has asked any questions.
Or raised the hand?
No, Dr. Shailesh has not put his hand down yet. Thank you. Okay.
Sir, one regarding this compartmental syndrome, if the patient comes late after 4 days.
Yes, that's a very interesting question. Actually, we have seen, Dr. Angeline also will remember that we have seen when the patient comes after 4 days, is it worth doing a fasciotomy? Is it indicated? Second, even if it is indicated, is it worth it? Are we going to save anything? If the patient is coming after 4 days, one, the distal hand is viable or the distal hand is necrosed. Two things can have occurred. If the distal hand is viable, doing a fasciotomy will help to at least for the function of the muscles of the fingers. If the hand is necrosed, there is no problem. You do a fasciotomy, that will at least, it will control the level of the amputation that you're going to do. That is what we have seen. We have observed that. So even so, the bottom line is whenever the patient comes with a tense brawny edema on the forearm, do a fasciotomy. Lot of people say, what if you are doing a wrong fasciotomy? See, when there is a patient coming with a problem in the forearm, okay, it is tense and tight. Either you do a fasciotomy or you don't do a fasciotomy. The
Yes,
two
yes.
other points are fasciotomy is indicated, fasciotomy is not indicated. If fasciotomy is indicated and you do a fasciotomy, well and good, you have done correctly. If a fasciotomy is indicated but you don't do a fasciotomy, what will happen? What will happen, Teja? If the fasciotomy is indicated but you don't do a fasciotomy, what will happen?
Further progress of the muscle necrosis or
Yes, muscle necrosis, and then you may also lose the vascularity of the fingers. Okay, the tips of the fingers may be involved, and you will have a totally functionless, you know, Folkman's ischemic contracture. So that is what is going to occur. Okay, right. Now I'll come to the third situation. Fasciotomy is not indicated, but you did a fasciotomy. So what will happen now? Anything lost? Yes, there is only one problem. There is a scar on the forearm. That's all, nothing else. Okay, fasciotomy not indicated, you don't do a fasciotomy, well and good. That is okay. So now the only drawback is fasciotomy not indicated, you do a fasciotomy. The only thing that happens is a scar on the forearm. So now, do you realize that it is better to err for the benefit of the patient, right? So that is why I rely more on clinical examination and clinical suspicion of a compartment syndrome. And if you have the manometric measurement, it's well and good. As Madam said, you can document that. But a clinical examination is most important.
In cases where fasciotomy, certain times the gangrene sets in, we amputate at a lower level, but when you see the proximal muscles will still be tight and we may be just making incision and releasing and leaving it, even when we are doing the surgery at 4 days, madam. We may not actually be able to salvage the gangrenous portion, but whatever is little proximal, we may be able to salvage better. That way, fasciotomy at a later level will still be helpful in salvaging a little more portion of the remaining muscle that is there.
And muscles.
Level will be lower than what we can with without fasciotomy.
Yes.
Without failure.
Yes, exactly. Now, Dr. Sundeep has also joined us. Does Sundeep have?
One more question I want to ask you,
Resident,
sir. Sandeep is out of country, sir.
No.
So,
Okay.
Sharika is.
Oh, she's handling that. Okay, right.
Foreigners are also in the meeting, sir.
Huh?
Foreigners are also in the meeting.
Oh, I see.
That's a good thing.
Oh. Sir, Dr. Karthikeyan, one more thing I would like to ask. There is segmental loss of nerves, both ulnar and nerve.
Yes.
What will you suggest in?
Madam, it is already how many hours? We started from 2.5 hours, more than 2.5 hours. However, since you have asked this question, it's a very interesting question. I mean, I know you are so interested in teaching and all that, but I do not know if others will be so energetic to listen. See, when there is a segmental loss, this segmental loss can occur. You can recognize the segmental loss in two situations. One in the acute stage, second in the chronic stage, that is the Folkman's ischemic contracture. Now, in the acute stage, it's very difficult to make out anatomically whether there's any loss or say of the segment, unless it is a trauma. In a trauma, you can make out that the segment of nerve is lost. But in a compartment syndrome, it is very difficult. I told you, when you do the fasciotomy, you see the entire length of the median nerve and ulnar nerve. Even if it is involved, you cannot make out much except one small finding. You can normally you can see the vasa nervosum running on top of the nerve. If the nerve has been involved, only that will be lost. You will not be able to see the vasa nervorum. That is the only small finding. But even then, we are not going to cut it off and reconstruct. So that way, I think that we need to go conservative in the acute stage. Whereas, when the patient, if the patient presents with the Folkman's ischemic contracture and you do an exploration, You can make out beautifully if the nerve is involved. As you said beautifully, the segmental loss. The distal median nerve, you can make it out beautifully. Proximal median nerve, you can make it out distally. In the middle, it will be a thread. It's very characteristic. In that situation, there are different ways of dealing with this segmental loss. If it is a small segment, up to around 4 to 5 centimeters, you can put a non-vascularized nerve graft, right? But again, we need to remember that a nerve graft, the healing of a nerve graft or the growth of the nerve through the nerve graft will depend on certain factors. It is not only the length that is going to depend upon, it is also going to depend on the amount of scarring around the tissues. If you're going to put a nerve graft in a highly scarred bed, you can say goodbye, it will not grow at all because the nerve depends on blood supply from the surrounding tissues. And in a scarred bed, it will just not grow at all. The same thing what you can do is you can put in a vascularized nerve graft. Vascularized nerve grafts are of two types. You can put a pedicled vascularized nerve graft or you can put a microvascular vascularized nerve graft. This vascularized nerve graft, usually we use the saphenous nerve. If you're going to do a pedicled nerve graft, which is simpler, there it can be done if both the ulnar nerve and median nerve involved. What you do is dissect the proximal median nerve which is intact, which is looking good, dissect the proximal ulnar nerve that is looking good and loop the two together proximally, almost at the level of the proximal forearm. Then in a second stage, divide the ulnar nerve at the level of the arm, rotate it downward and suture it to the distal median nerve. This way, you're reconstructing the median nerve alone, sacrificing the ulnar nerve so that gross function of grasp and pinch can be achieved. This is the method of reconstruction of a nerve graft.
Okay. Excellent, sir. So we had a very good interactive session and description of the electrical burns completely covered all aspects. I thank each and everyone, especially Dr. Angeline Madam and Dr. G Karthikeyan sir and Dr. Tejaswi presented the case very well and answered also promptly all the questions asked by Karthikeyan. So I thank Dr. Angeline Madam and Dr. Karthikeyan for accepting to come to participate in plastic waste program and delivering very nice, good lecture and case discussion.
I would like to thank Dr. Umar also. In the beginning, he was looking like the model in the ad for Nescafe. He was having a nice. I thought there's an advertisement going on for Nescafe.
I had just reached home that time. Na? I was just having evening tea.
No, you are looking like a model having Nescafe mug, no?
Thank you, sir. Thanks a lot. Thanks for the compliment.
I
really enjoyed the session. Really enjoyed the session.